So good afternoon, everyone, and thank you for joining us for our third workshop for this rulemaking. My name is Amelia Boyd, and I am the program manager for the WMC, and I'll be facilitating today's session. This workshop is being recorded, and we'll post the recording to our YouTube channel soon. The documents we'll be discussing are available on our website at wmc.wa.gov. In this slide deck, the globe, which links to our website, and the YouTube icons are clickable and will take you directly to those resources. For attendees, if you'd like to ask a question or make a comment, please use the raise hand function. We'll call on you as soon as we can. When offering comments, please avoid reading aloud any written remarks that are already included in the materials. These workshops are intended to be collaborative with a back and forth exchange of ideas about the proposed language. Before we get started, I'll take a roll call of our panelists and staff. When I call your name, please introduce yourself. Marlon?
Good afternoon, Marlon Basco with the Department of Health, and I support Amelia and the Commission with rulemaking.
Ms. Blake?
Good afternoon, Christine Blake, public member of the Commission.
Dr. Chang?
Hi, good afternoon. This is Poshin Chang. I'm a retired family physician. I'm also a commissioner.
Thank you. Marissa?
Marissa Courtney, licensing manager for the Commission.
Heather?
Yeah, good afternoon. Heather Carter, Assistant Attorney General for the Commission.
Kyle?
Good afternoon, everybody. My name is Kyle Kiernan. I'm the Executive Director for the Commission.
Micah?
Good afternoon. Micah Matthews, Deputy Executive Director, Staff to the Commission.
Thank you. Dr. Domino, please introduce yourself and then begin the script.
Okay, hi, I'm Karen Domino. I'm one of the commissioners. I will be the presiding officer for this rules workshop. Today is Monday, April 20th, and it is now 1:06 p.m. The meeting is being held via Teams webinar. The rule being discussed today is regarding WAC 246-919-010 through 246-919-520 and WAC 246-919-602 through 246-919-700, which sets standards for allopathic physicians or MDs. The CR 101 or pre-proposal statement of inquiry was filed as WSR number 25-12-014 on May 22nd, 2025. Ms. Boyd, please present our proposed timeline for rule development.
So here's the proposed timeline for this rulemaking, which may be adjusted as workshops are held. Are there any questions about this timeline? If so, please use the raise hand function and I will call on you. Looks like there are no hands raised.
Hands raised. So thank you, Ms. Boyd. We will now work through the rest of the agenda items. At around 2:25, we will pause the discussion to review next steps and dates for future workshops. The next item on the agenda is a discussion of proposed new section WAC 246-919-604, physicians providing advanced procedure support to optometrists. Mr. Karenanen will provide some background information on the proposed language.
Thanks, Dr. Domino. So this is another step along the line that the Commission started in 2023. In 2023, the legislature passed legislation that expanded the scope of practice for optometrists under certain conditions and limited to certain procedures. In November of 2023, the Commission had a meeting where it considered whether or not to adopt a interpretive statement with regard to parts of the language within that law. The decision of the Commission at the time was to put that on hold while the Board of Optometry, your colleagues at the Board of Optometry, went through their own rulemaking process. In I think it was roughly April or May of 2024. Dr. Murphy and I met with the Board of Optometry informally and raised a couple of questions and concerns as their rulemaking was going forward. And then we sent a follow-up letter to the Board of Optometry shortly thereafter. In May of 2025, the Commission adopted an interpretive statement with regard to the provisions and some of the concerns that had been expressed. And as Heather will undoubtedly remind us, normally when you have an interpretive statement on file and it rises to a certain level of complexity, the next step in that interpretive statement's lifespan is to consider whether or not to adopt a rule in that regard. So you have the rule language in front of you. It is substantially similar to what has been discussed in general terms with the Commission over the last couple of years. But we're now at a point where in the workshop process, we can accept comments, we can accept questions from the Commission for staff and or Heather in terms of what is in the proposed rule. But this is, again, just kind of a milestone on the entire process. So Dr. Domino, Dr. Chang, Ms. Blake, I don't know if you have any questions.
Any questions? I don't.
I do not. Thank you, Kyle.
No question.
Okay. Well, if you have a comment, a question, or suggested language as we work through the draft, please use the raise hand function within the Teams platform, and we will call on you as soon as possible. Ms. Boyd, will you please present the proposed language for this new section?
So here is the proposed language. This has been the, excuse me, language since, well, earlier last month. And I believe it was actually the language that we had in our January as well. And so some of the language that is here is already in our interpretive statement that Kyle mentioned. And this is what we're presenting today to be discussed. And if you have any questions about that, I'm here. Kyle's here. Mike is also here to answer any questions. We did receive several comments about this particular section. Some of them were prior to the change of language where we were defining qualified physician, but we have taken that piece out and have changed it to what are the requirements for physicians that are providing this support to optometrists. So we are no longer defining qualified physician, but instead talking about what physicians are required what their requirements are when providing this support. So I'm not sure if you've had a chance to review this language.
I did, and I'm in agreement with the way it's written, with the changes made.
Yeah, that paragraph is fine with me.
It's fine with me too.
We will move to the next subsection.
I have no problem with that either.
That looks fine. I can't see beyond the second line of C.
Right.
I think, yeah, it's just a matter of scrolling a little bit.
Mm-hmm.
We do have one hand raised. Melissa, go ahead.
Hi, my name is Melissa DeCumos. I'm an optometrist in the state of Washington and also a member of the Board of Optometry, and have been aware of, the interpretive statement that has come in. And now that this is into rulemaking, I just wanted to ask for this particular section. I know the stance of the WMC has been to limit the qualified physician to ophthalmology only. And I just wanted to state that if we think about the entire state of Washington, in particular rural parts of the state, there are far more optometrists than there are ophthalmologists. So if this law with the intent of increasing access to care, if we limit the arrangements, the agreements with ophthalmology only, then it then further limits the ability for optometrists to perform these procedures and provide that care to those in need. So that was in being involved at the board with the language here on our part. Our thinking was that we didn't want to limit it to ophthalmology, especially if there were relationships established with primary care providers, ER docs, or any other type of physician who would feel comfortable managing any potential complications. So I just wanted to put that out there as a consideration.
Like Christine?
Thank you, Dr. Domino. With regard to your comments just now, are optometrists holding staff privileges at facilities so that if you were called in, you would have the privilege to do so?
So are you talking about in hospitals?
Yes.
We do not, no.
Okay, so my question
Go ahead.
my question would be then, if in fact something happened at a facility, a hospital, surgical center, and they had to call in an ophthalmologist, that ophthalmologist would either A, have to have privileges there already, or get temporary privileges, right, to treat that, to assist with whatever that needed call was that had to get there within 30 minutes. So I'm just throwing that out there, that if there's going to be a change to that, then you'd have to reach out to those facilities as well to discuss how those privileges would work out.
Micah?
Sorry, I thought that Melissa was going to have something to say to Miss Blake, but I'll wait and see
okay.
if that's the case.
We'll see.
Yeah, so Ms. Blake, I'm having a little bit of a hard time following. So if I understand correctly, what you're saying is if a procedure were done and a complication were to occur and they are sent to the ER.
Correct.
And the complication could not be handled by the ER doc, assuming that the optometrist has a relationship with that ER doc and created an agreement with that ER doc, who agreed that they would be able to handle and manage these particular complications. You're saying that if that ER doc had to call the ophthalmologist to help.
What I'm saying is, if you have an agreement with the ER doc at the facility itself, the ER doc can't just call you unless you also have privileges at that facility to come in and treat that patient. Or unless you've arranged something that you're aware of at other facilities where you have a contract with them and you do come in. I'm just pointing that out for you, just in general, for coverage for you. You'd have to present liability insurance, where you practice, references, all those things. So in order to enter that facility, so if that's the case, and I'm just pointing it out for awareness.
Absolutely.
Yeah.
So I'm aware, I understand that, but so usually how optometrists practice is if we're going to do these procedures, we tell our patients that should a complication occur, and we go over the potential complications, to give us a call rather than go directly to the ER.
Okay.
Now, if you're the optometrist, you see that a complication has occurred, and then you reach out to an ER doc who you've got an arrangement with, that's a different scenario where the optometrist doesn't have to go into the hospital.
Okay. All right. Okay. Thank you for that clarification. It's just if you're going to enter the hospital, that's a whole different situation. Yeah.
Absolutely.
Yeah.
Micah?
Sure, just a couple of things as this has been developed. The first thing is when this bill was being debated and passed, there was a study put forward by the University of Washington using global positioning data for all licensees and their stated their stated location, and in that it proved demonstrably that you're never more than 30 minutes away from an ophthalmologist, and that's based off of their actual license address. So that's number one. Number two, we did consult with the various family medicine groups, emergency physician groups, and ophthalmology groups in looking at the advanced procedures, looking at what would make sense for this. To the last professional association, they were not comfortable at all with an optometric case coming in that had complications into the ER. In fact, they quite clearly said there's no way, there's not enough money you could pay me to work on an eye in an ED. We would call an ophthalmologist, period. So we have to take some consideration in their feedback and how we move forward on this. And then finally, the aspect of these procedures and their complications, we did bring this to not just the ophthalmologic association, but also individuals that we work with at the commission who are pro tem members, just trying to understand the clinical aspects of this. And that's what really helped us settle on this language, in that the time of complications and what could be a permanent is measured in the form of hours. And so that, in that particular case, made it clear that the best solution for the patient is that an ophthalmologist is who is the one that needs to be with the arrangement, so there's not a delay in care.
And that's typically who the ED calls.
That was the feedback we received from every ED physician we talked to.
Right. Exactly. Yeah. And that's who would be on their call panel.
MM, sorry, I don't know who you are.
That's okay.
It's
Can you hear me
Mark.
okay? Can you hear me okay?
Yeah.
I'll just introduce myself briefly. Dr. Mark Merriman, I'm an optometrist. I practice in Chehalis, Washington. I'm representing optometric physicians of Washington. So first of all, thank you to the committee for your time. One, I just wanted to recognize the awkwardness of this, which we understand. What I mean by the awkwardness of this, you have two independent provider groups, medicine, MDs, and optometrists with separate boards. And then, of course, statutes aren't always perfect when they're written, right? And sometimes then they require some awkwardness in the rulemaking. So we recognize and understand the awkwardness to this, particularly the independent nature. It's different than if this was a physician assistant, which is regulated under the medical doctors. And so, having two boards writing rules, optometric physicians of Washington have concerns that we're going to get disparities between those two rules and these agreements. Also want to recognize the awkwardness that this is a really unusual statute. Sometimes things get passed in order for things to get passed. But this is so unusual because I think most of the medical doctors on this committee would recognize and agree. If somebody is doing a procedure, I don't care what provider level they are, if they're licensed and certified to do that procedure, it's really rare to have an agreement like this. Generally, if a complication arises that provider can't handle, that provider has their source of referral networks, right? For instance, I work in an optometry practice. The ophthalmologist has a complication, a general ophthalmologist, a cataract surgeon, for instance, has a complication such as a retinal detachment that they can't repair themselves. They have relationships with retina specialists that they refer to. And it's really unusual to even have an agreement like this in place. In fact, I'm not even aware of any other states that have an agreement like this in place. So we recognize that, we understand that, from the start of all of this. With that said, the concern that OPW has is that some of which optometry has already passed, the Board of Optometry, I should say, has passed. There's some disparities in what has passed and what's here. And as we go through the language, I can highlight those things, but particularly having an arbitrary set number of agreements that can be in place, keeping in mind that these procedures we're talking about optometrists doing, of which I do myself, by the way, these procedures, we're talking about a rapid response agreement, right? So we're talking about things that require minutes or hours type of response. Things that I would think of like that would be uncontrolled bleeding on a procedure that required suturing. Since the scope does not allow for suturing for optometrists, this bill, very rare for that to occur with the types of procedures we're talking about doing. Most of the procedures being done in this bill will allow for things like chalazion and hordeolum removals, which are lump and bump removals on the eyelid and surrounding adnexa, subconj injections into the eye. And so, normal complications wouldn't require rapid response, right? That could be handled by the optometrist. So we are specifically talking about rapid response things, which in my opinion are going to be so few and far between. We're talking not even every year. So to have limits on the number of agreements that can be signed, to me is a bit arbitrary, particularly given the circumstances of which are the types of procedures of which we're talking about being performed. And then again, not having agreement with reporting. Our other concerns that what we would hope to not see is to have language which puts as many administrative hurdles as possible to discourage any ophthalmologists from signing these agreements, and particularly from reporting. And just so the commission's aware, the optometry board already, actually not the optometry board, the statute itself requires reporting of any complications, not rapid response complications, but any complications to the Department of Health. So, so requiring an ophthalmologist to require a rapid response or to report a rapid response is a little bit repetitive because it's already has to be reported to the Department of Health. So I guess what I'm saying is we're wondering the reason for this, because the statute does not require the medical commission to do any of this, doesn't require them to write rulemaking on this in statute. I believe Senator Cleveland sent a letter to the board recognizing that, who was the prime sponsor of the bill when it passed. And so we're all for safety. We're all for responsibility. We recognize the awkwardness of the whole thing here, what we're speaking about. And we want to work with the board to make sure that it's a safety issue and not just an administrative hurdle for any ophthalmologist signing these agreements is what we want to do moving forward. Thank you.
Number 2.
It's Melissa.
Yeah.
Yeah.
You're on mute.
Sorry, I
Yeah.
just unmuted myself. Thank you. Just to respond earlier to some of the comments that were made, I think it was by Matthew. I know that he had talked about how there's never an ophthalmologist greater than 30 minutes away. And that may be true from multiple locations throughout the state. That may be true, but also not every single ophthalmologist is going to agree to enter into these agreements with the optometrist. And although there's research in that questioning into ER docs as to whether or not they would feel comfortable handling these complications, when you set these agreements, you actually, as an optometrist, we have to go individually to that specific doctor and ask them if they're willing to sign the agreement. In many instances, you're telling them verbally and on written, this is what I'm looking for. This is, should something, as Dr. Merriman was saying, where it is truly an emergency that does require a true rapid response, are you willing to enter into an agreement should someone continue bleeding and we can't get them to stop bleeding? And it would be up to that ER doc to say yes or no. So, and if they say no, then that's the answer to no agreement. So that's why I challenge the fact that we're limiting this to ophthalmology only, because in my opinion, I would think even like a PCP, should they be able to handle something like this, if they agree that they can handle it and are comfortable handling it and would enter into that type of agreement, then why do we not leave that as an option in order to provide this particular care to patients? And I do also want to point out, and I'm trying to stick to the sections that are that we're revealing each time here, but I do want to point out in section 1D It does say local to the ophthalmologist is considered within 30 minutes or less of surface travel. I was curious to know why it needed to be specified as surface travel. I think as long as we provide care, necessary care within a necessary amount of time, let's say within an hour or within 30 minutes, why do we need to specify surface travel?
Thank you. WD?
I think that's Billy.
Hi, I think that's me too.
Yeah.
Hi, everybody. I'm Billy Dickinson with the Washington State Medical Association. Thank you for the opportunity to provide comment. We represent physicians of all specialty types. We co-authored the letter with the Washington Academy of Emergency Physicians, and I just wanted to second the comments from Micah. ASAP's position, and it has been their position when this bill was in front of the legislature, is their position now. It was their position when this was a sunrise review. The management of adverse events involving the eye or around the eye falls to an ophthalmologist. That is their position. I just wanted to make that very, very clear. Thank you for the opportunity to provide comment. I'll hold the rest of my thoughts for later.
Thank you. Kyle, you had previously had your hand up, but now it's off.
The comments that I were going to make have been addressed. Thank you.
Ms. Blake.
Thank you, Dr. Domino. So the response times are because of EMTALA. On-call physicians' response times are generally required to be within 30 to 60 minutes for in-person or 15 to 30 minutes. And for in-person arrival, phone responses could be within 15 to 30 minutes, and they're mandated by hospital policy and EMTALA, which is why there's a time frame on this. So when a hospital is surveyed and they're looking at their EMTALA rules and policies, they're checking to make sure that it isn't a wide open response time for when you have an on-call physician come into the hospital and take care of a patient. Because, we all know that time is of essence when there's an emergency. So that's the reason for that.
Go ahead,
Melissa.
Yeah.
Yes, thank you. Yes, Ms. Blake, I understand the time frame, but I guess my question is the reason that it needs to specify surface travel versus air travel, for example.
Well, air travel is a little dicey, right? You're not necessarily always on the plane. Where would you be traveling from by air?
I don't know.
Yeah. You'd have to get on a plane, come out, see the patient, and that's more than 30 minutes to 60 minutes would be my impression.
Right, but you're assuming that, no?
Yeah, I work, my background is hospital administration and medical staff, peer review, quality, and all of the above and the policies. And every facility that I've worked in and have had folks come in and review them, Joint Commission, DNV, have always looked for this kind of a response time that you can get to with your office being at least within 30 minutes or so, 60 minutes at the most away, which wouldn't mean you need to get in on an airplane and get to the hospital. You're just going to get in your car and go to the hospital.
Any other comments? There's Dr. Chang.
Okay, so do we have is the advanced procedure as defined anywhere in the rules? Because I think when I'm just listening to everybody, I think everybody's coming from a different point of view, and they're imagining advanced procedure, differently. Because from what I'm hearing from optometrists, they talk about lesions, and they say, yeah, they got something, they couldn't stop the bleeding, they need to put a suture in, and since they're not required to do, or they don't have training to do that, they need a MD to do that. And so that's why they're thinking of emergency room doctors, primary care physician to put a suture in. But as a practicing primary care physician, anything involving our eye, we always worry about liabilities, and we repair anything on the eyelid, you can potentially end up with increasing risk of liability of disfigurement. So that's why, that's where from the pushback from the emergency room doctors and primary care physicians say, if this happened, we're going to end up with optometrists, ophthalmologists to do the repair, rather than ourselves to do that.
Kyle,
Dr.
you
Chang,
sent something
Kyle
in the
just
chat. Yeah.
Yeah, Dr. Chang, Kyle just put the link to it in the chat.
Okay.
It is, I believe it's defined in statute. If you need more detail, I think about a year or so ago, we worked with one of our pro tem ophthalmologists to identify the procedures and the potential complications that were associated with those. And so I could send that to you once I dig it up somewhere if you needed that.
Okay. And also the second question is, I was thinking about the rural, rural hospitals. So if you have a optometrist kind of have a say agreement with the emergency room doctor, and then once the patient gets there, the emergency room doctor say, well, it's beyond my ability, then it's up to the emergency room doctor to, and if they don't have the ophthalmologist on staff, they have to transfer, right? They have to transfer to a different place. But that end up with the emergency room doctor's responsibility, but not the optometrist's responsibility, correct?
So, I guess it would depend on the particular complication. So if it is a complication from the OD and they got in touch with the ER doctor that they have an agreement with, that is assuming, depending on that complication, it is something that they either can't or is outside of their scope or they're unable to handle. So I could see how in that situation, yes, if the ER doctor is not comfortable managing it, they'd have to get a hold of the ophthalmologist. If it is a patient of yours that is after hours, like I was saying earlier, the emphasis is always that if there's any, issues about discomfort or pain or something that can be managed by the optometrist, it would be that the optometrist would see the patient in their office.
See, I think it was number 1, had hand
Yeah.
raised.
Yeah, Mark Merriman again. Yeah, to answer the question, it's not a matter of training regarding suturing. Optometrists have training regarding suturing. It's a matter of the scope allowable. And so the way the scope was passed, it did not allow for suture closure of wounds. That doesn't mean that optometrists don't have the ability or the training to be able to do it or the competency. It's not allowable in Washington State. The other thing I was going to mention is and this is just personal experience. We take call. When I say we, my clinic takes call for 2 hospitals and multiple urgent cares in Lewis County. The optometrists like myself for the first call, we handle 99.9%. I've been working for 17 years. Over those 17 years, I've had to call in an ophthalmologist maybe a handful of times. The optometrists handle 99.9% of ER physician calls regarding eye care issues. Some of those issues, and the main reason why is because they don't have the equipment for me to be able to go into the hospital to be able to see it. So the patient is transferred to me to see it in our clinic because we have specialized equipment to be able to see that patient. It's usually just easier and better. Occasionally, our ophthalmologists have to go to the hospital to see a patient there when they can't be released, right, if they're admitted to the hospital. And so it's again quite unique in that respect. But I just wanted to clarify that some of these laws are not a matter of can the optometrist or the optometrist capable of doing it, but does the law allow for that? And so the reality is, even if we're capable, but the law doesn't allow, the simple matter of the fact is that has to be handled by somebody else, right, other than the optometrist. And so I just wanted the committee to understand that. The commission, sorry. And I apologize. I have a patient that I have to go see. So I'll be back and forth. I apologize.
Anyone else have a hand raised or anything? I know they're Amelia, do you see any more? I don't.
No, I don't see any other hands raised.
So should we move on?
Oh, I have a question. So we're assuming that, optometrists practicing, is usually independent, practice. But what about those ones that are, say, working at, say, like Costco or, like optometry? Would that even that they end up then say it's from the business standpoint, now that they're expanding for the Costco optometry to also perform those advanced procedure, or it's just simply dispensing, glasses prescription?
I think they just dispense. Dr.
Yeah,
Chen.
but
at Costco,
what I'm
yeah.
thinking is that what if there's in the future those big, kind of, business entities that what they want to include that, would that end up to say, okay, now we're doing the procedure in that, but then who are they contracting with, or are they just going to end up bringing an ophthalmologist into that fold to do that?
Melissa, did you have a comment?
I do, yeah. So it would be up to the Costco commercial doctors if they wanted to do these procedures. Often, just the way their setting is, they not just with this, but with other medical issues, they don't manage very much of that to begin with. So it's a setting that's very hard to create a clinic or create time to do those types of procedures. My guess would be that they would choose not to do it just because it's not conducive to being able to provide that type of care.
Okay. Yeah, since I practice in a like kind of sort of like a multi, specialty clinic settings, and so certainly, in my setting, it's basically unique to, it's not applying to the small independent practices. And so basically in our setting is that usually it's the optometrist acting as kind of just acting as the primary care for the eyes, and then they have direct link to the ophthalmologist who's serve as consultant. So it's never been an issue like we're seeing here. So to me is that this is actually, it's a lot of work, so.
If I may just say one more thing, I think Dr. Merriman was alluding to it, but this whole physician agreement, just to kind of put it into perspective, of all the other states that have these procedures, there's no such thing as this physician agreement. It is definitely unique. And it was it's just a very odd and unique addition to the legislation.
What are some of the other states that have this legislation?
Off the top of my head, I'm thinking Oklahoma, New Mexico, Alaska. I could bring you a list of them, but there's a lot of them.
Okay, thank you.
Mm-hmm.
Should we move on?
There's no other hands raised right now, so I think
Yeah, I don't see any.
I think you were good through C. There was some discussion about D, but I'm not sure how the commissioners feel about sub D.
Isn't 30 to 60 minutes sort of the usual? I mean, I'm thinking about, I live a few miles from where I work, and it can easily take 30 minutes to get here. So I think most, people taking a call from home, it is that. Isn't that not correct, Christine?
The typical is critical access hospitals have 60 minutes that were might be acceptable. Acute care facilities, it's usually I've seen it in policies at 30. But yeah, but it is, it could be 30 to 60. And, the ER doc would obviously work with the on-call practitioner about the urgency of the issue that they're calling. about. So it could be 30 to 60 and it dependent on what that patient is in need of. And
Do
how
you just
quickly
want
we
to,
need them to get there.
do you want to change it to 60 minutes or
No.
say 30 to 60 minutes?
I wouldn't change it to 60.
Okay.
30 to 60, because it tells you what you know, there are things that are, you should be there in 30 minutes.
Mm-hmm.
60 is, there are
Yeah.
other things you,
Right.
So are we good with D the way it's presented here then?
I am.
30 minutes or less.
No,
So
we don't want to say, yeah, well,
I like 30 to 60 minutes.
60.
Oh, okay. You do want it to say, okay.
Yeah.
Yeah, we were saying that not just 60 alone.
Got it. Okay.
The
Yeah.
range.
The or less is fine. I would leave that.
Okay. So are we good with D now?
I am.
Yeah.
Well, I don't know. I mean, do you want to give that just 30 to 60 minutes? I mean, it's still, you're talking about less than 60 minutes. So wouldn't it be,
I
to make it
guess it
simple,
could
just
be
say
less than
within 60 minutes and then take out the less or less?
That's fine.
So the typical response standards are emergency stat cases within arrival expected within 30 minutes. In-person arrival is usually within 30 to 60 minutes, depending on hospital policy, time of day, and severity of the case. Telephone within 15 to 30 minutes. So those are the typical timeframes you see in policies and are in EMTALA approved timeframes.
So it could be 30 to 60 minutes and get rid of the or less, right?
Yeah.
Yeah. Someone says change to 30 minutes, especially given the rural nature of Washington, much of Washington.
Right.
And that was a comment from last fall from the Washington Academy
I
of
see.
Eye Physicians.
Okay.
What
Yeah.
do we have before? 15 or something?
I
Yeah, I
don't
don't know,
remember what
but
it was before.
Yeah.
I'm not sure we had anything before.
We may not have. Mm-mm.
Okay.
Okay, so we like D now.
Yes.
So we're moving on to sub 2. We won't be able to see all of sub 2, so we might have to scroll back and forth a little bit. Are we good with 2?
Yeah.
Mm-hmm.
Okay, so 3 is pretty long.
Yeah.
There's a hand raised. I think the first one was, yeah.
Go ahead,
Sorry,
Melissa.
Melissa, yeah.
Yeah, thank you. Yeah, I'm curious to know for 3A, the reasoning behind limiting the number of agreements to 3 per physician at one time.
Go ahead, Kyle.
Kyle?
I can speak a little bit to that. Part of that is the commission's experience with collaborative drug therapy agreements and pharmacists, where every now and then we would have complaints or issues or concerns arise, and we would look into and investigate these, and we would have physicians that have 2,500 at one time, which I think was a concern of the commission in terms of their ability to actually provide that networking and collaboration with pharmacists. So I think that that's partially the idea behind that limitation.
Kyle, it seems like, you know, especially with an ophthalmologist, there aren't that many around. And it seems like 3 is just a little arbitrary to me. I don't know, it's just my gut feeling about it, just picked. It's different from several hundred, right?
I think that's fair. I think that, you know, Dr. Domino, one of the other concerns that we had and came through in comments is the ability to kind of adequately collaborate with partner optometrists in these sorts of arrangements. So if you think that there's a better number or a more appropriate limitation, I think that's fine. You know, the purpose of the workshop is to kind of work through some of these, some of the structure of what we're proposing. So if you think that there's a better number that works, certainly go ahead and propose.
Melissa, you have your
Yes.
hand raised.
Thank you. Well, 3 agreements seems quite stringent, in my opinion. So again, we're talking about rapid response for something that really needs to be addressed right away. And given the procedures that are being done, and also taking into account, you know, I'm not sure if the commission's aware of the process of getting an advanced procedures endorsement. So I think it's really important to know that not all optometrists automatically can do all of these procedures. You have to go through training, you have to get your physician agreement, you have to fill out the application, et cetera. It's kind of this process that takes quite a while. And if the courses aren't available, it may not happen for another year or so. So as it is right now, I don't know how many optometrists are actually endorsed for these advanced procedures. I would venture to say it's probably less than 50 in the whole state. So it's a very small amount of optometrists. Having said that, understanding that the legislation is new, the idea is that more optometrists would get endorsed. But if you actually think about, first of all, that small number, and then also how many will actually require a rapid response. We expect that the complications will be extremely rare, especially when you think of the procedures that are being allowed to do, that we're allowed to do. I mean, if you think about the little lumps and bumps that, and I'm not talking about chalazions, because I think a lot of optometrists tend to be pretty conservative with what they feel comfortable managing. And I think one of the last things will be chalazion removal. One of the first things will be removing a skin tag right around the eyelid. And as you all know, the epithelium of the skin is pretty easy to work with. So the chances of a true complication occurring that requires a rapid response is going to be extremely rare, if it even happens once a year with that one ophthalmologist. So if we're thinking about places like rural Washington, where there aren't very many ophthalmologists, and you have optometrists surrounding them, and all these different optometrists are hoping to get an agreement with that one ophthalmologist, but the ophthalmologist then is only limited to 3. The intent of the law was to increase access to care, and it really significantly limits that with a number of 3 agreements. And also given that we expect that the complications will be pretty darn rare, given what the actual procedures that we're doing.
Dr. Nicomas, do you have numbers on the complication rates for the various procedures?
From across the country, or what demographic, like what Are you talking about within the state or?
No, just generally. So when we engage with the Board of Optometry on this, we sent a letter saying these are the complications that we see out there that may need that rapid response. And so I'm curious. So take, for example, I don't know, lid skid lesions. How often does that actually occur? A complication from one of the advanced procedures that the legislature has put into statute?
I don't, like, I can't give an estimate based on Washington ODs because there's barely any of us that are doing these procedures. But I think physicians are fairly aware that the skin, the epithelium around the eye and lid is fairly heals fairly easily. So us removing a skin tag, honestly, I have a hard time believing that there's going to be any complication that's going to require a rapid response from something like that.
But you don't have numbers or statistics on kind of complication rates for any of these procedures?
No, I don't. If you'd like me to get some, I can.
Yeah, sort of national numbers. I mean, that gives you
Sure.
a feel about it. I mean, we suspect it's very rare, but because a lot of complications are very rare, but we'd like to have, there must be something out there on
Absolutely.
risk. Yeah.
So is there a number that you have in mind to change the 3?
Well, I don't know. I mean, I don't know how many, I was going to ask Mark, how many ophthalmologists are there in his group versus optometrists? Okay, just as a thing. I mean, I don't know. Are there 2 ophthalmologists and 10 optometrists? I mean,
I work with Dr. Merriman, and in this practice of the whole company, there's about 40 optometrists and about half as many, 20 ophthalmologists.
mhm. I mean, I guess I'd like to see what the complication rates are. They sound pretty low. So does 10 seem fine to me? Sure, I'd pick a number of 10, but I'm not sure that's an appropriate number.
But didn't Dr. Merriman say that only about 1% of things that would actually merit that they ask for ophthalmologists and they handle 99% of emergency? So that to me is already pretty low. I'm looking at, if you're talking about, 10 is, basically it loves margins, it's, 10 seems to be a good, starting point, even though it's arbitrary, I'm okay with that.
Do you have
Any
any
other
thoughts, Ms. Blake?
comments? No.
No, I do not.
So is that acceptable to the optometrist, or they don't want to see a number there?
I don't, we would prefer not to see a number there, honestly. There's a lot in these draft rules that we'd prefer not to be in there. But my question would be, should it not be up to the ophthalmologist to say, I've got enough agreements? I guess I'm just trying to figure out, first of all, where 3 came from, and then why, if I were in that situation, I would say, I'm unable to sign any more agreements. That's kind of how I would go.
Micah, you have something that appeared for 10 seconds and then left,
Oh.
or 5 seconds too.
Sure. Yeah, just a hand raise. Yeah, to try and address that. So number one, Kyle did address your question, Melissa, and that is when, with our experience, number one, we have to worry about that 0.01% because that's what comes to us and that's what we have to deal with. The second thing is when there isn't a limit, we have seen in real time where people don't limit the numbers that they can safely do. And so not only do we have to impose some sort of limit so people actually can do what is in the spirit of these collaborative agreements, but also the legislature has done the same thing in the past 3 years. Everything from limits on how many collaborative agreements you can have with a physician assistant to how many supervising agreements you can have with an international medical graduate doing clinical experience.
Right.
So the concept is quite sound and used both by us and the legislature frequently.
Micah, can you tell us what those agreements, what numbers those require? They're different than this, but just for our curiosity.
Yeah, historically PAs had, I believe, 7. You could petition up to 10, and then there's a grandfathering before they went to the collaborative agreement phase of 20. That was mostly in response to a telemedicine company that demonstrated how they worked and they presented to the commission. The IMGs, they have a limit of, I believe, of 4.
Kyle?
I would just offer the additional observation that, the legislature included language here that says rapid response. And that's certainly a concern, given all hours of the night that these complications may arise. And so when you're trying to figure out kind of bandwidth and where things should land, we have, as Micah was just mentioning, the collaborative drug therapy agreements, which I don't think are in a particularly great place just generally in terms of that aspect of supervision. But here you have the added additional command from the legislature that we're supposed to be looking, and these agreements are supposed to be crafted with the idea of rapid response. And again, to the idea of complication rates, but also onset of when those complications may show up and how quickly they have to be addressed. And so it's a balancing act for sure in terms of the access issues that Dr. Dakamus is raising, but on the same side, obviously, the overall structure here that involved the medical commission as well as the ASTIO board. So it's a balancing act for sure.
Thank you. Melissa?
Yeah, given that PAs have, I think I heard some sort of collaborative agreement of up to 20. Could we put in there at least then, if there's needs to be a number, 20 agreements?
That was a grandfathering of a specific case. The standard was 10.
It was. And now, Micah, correct me if I'm wrong, but I thought in 2026, there's no specific limit now on the number of collaboration agreements a PA might have.
That was when they went with a collaboration agreement with a different model. Yes. So it is a bit of an apples to oranges comparison on that one.
Yeah. So 10, you're right. 10 is the number at one time, but they could petition for a waiver to supervise more for a physician's limit. So 10 sounds like a reasonable number to be sort of along the same lines as others.
One option for flexibility we could consider, no apologies, is putting in for the ophthalmologist a petition pathway. So if there's a desire to do more, that would at least allow us to collect some data about how many actually want to go above the 10 and the reasoning for that. So I'm sure we've got some standard drop-in language that we could grab and do that.
Mhm.
We'd be in support of that.
Okay. Amelia, you're moving down? Or
Making a note real quick.
Yeah.
So we're good with 10 for with if we add in the petition language, right?
I'm okay with it.
Yes.
All right. Moving along.
May I ask for part B? Is there a reason that the agreement, the time frame of 12 months, was there a basis for that of renewal?
Several. Going back to the CDTA scenario, there were at least 2 scenarios that I was aware of where a CDTA was being acted on, where the pharmacist was in a collaborative agreement with a deceased physician. So that's just basic administrative upkeep.
I'm good with it as it reads.
yeah, I am too.
I'm okay with it.
Are you okay with how C reads now?
Yeah, I thought that's what we were saying was okay.
Yeah.
Okay.
Yeah.
Moving along then. Apologies.
D sounds good. It's in line with what we just already approved. And the rest of the
Mhm.
prior, when we talked about time. Unless you want to take out the miles and just say.
I'm
we're
wondering
no
why
longer-
we have the miles. I
Yeah,
mean,
we could just take
Because
out the
someone
miles.
living, if you're on a highway and you're driving, you drive at least
Yeah.
at 70 miles an hour in many parts
Yeah.
of our states, and you could get there well within that 60-minute period, even if
leave
the
that
distance
down
is
in there.
longer. If you live in Seattle and it's rush hour, it's different.
Right. You can leave the than in there, Amelia.
Micah, you had something in there. I didn't get to see it. It flashed by for 1 second.
That's just the track changes bubble doing it.
I
Yeah.
see.
That
Okay,
was
thank
me.
you.
That's why I was trying to get out of it. Okay, we're good with D now.
E makes sense.
E makes
is
sense.
good.
Yeah, I agree.
Okay. Moving on to F.
Melissa, you had a comment?
Yeah, just for E, so I've talked to some colleagues who have been trying to get their own physician agreements, and some of them will individually specify with the ophthalmologist as to what particular procedures that they're asking to be available to respond to. And but not necessarily all of them are asking that. So I guess coming from the board's perspective, there's a lot of things that the board, and just a reminder, it's in conjunction with the Department of Health. So anything that the board decides is still reviewed by the Department of Health, and then it's brought back and recirculated for conversation. So we did not feel the need to add something like that. And it just makes it more restrictive. I just wanted to know the reasoning behind adding that in your draft language.
Again, this is standard for most collaborative agreements and has been for PAs for as long as they've been here. You will stipulate as the physician what procedures or processes that you will work with that other individual on. It's never been stated as onerous or restrictive. It's simply a clear description and agreement of what the two practitioners will be doing.
The other thing that it qualifies to actually is what is that physician allowed to do in the hospital, so they can't go beyond the scope of the privileges that they've been granted within a facility. So that would that would be something that they would be able to say, I can do this, 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 and this. I can't do these. I don't have privileges to do that.
Mm-hmm.
So, and it might just be agreements must stipulate the specific procedures the qualifying physician has the ability to perform at their credentialed facility, or just leave it as is. But I understand why that's in there too, is there are some things they can't do because they don't have the privileges at that facility to do it.
And if I may, if we think about all the procedures that we're talking about here, I can't really think of anything that would require admission into a hospital. These are all office-based procedures. I know that for completion's sake, you have to state that their surgical center has to be nearby, their hospital has to be nearby. But any complications that would arise from some of these procedures would all be, for the most part, handled in office.
But what if they're not? Then you have this in there to cover that.
And I guess I'm confused because earlier in this hearing, you argued that you should be able to form an agreement with an emergency physician.
Mm-hmm.
So I guess the question is, which is it?
Mm-hmm.
Well, I was already on the path of thinking of ophthalmology. So clearly we're going to keep on the ophthalmology path, right? And so if an ophthalmologist were to handle any of these procedures, it would be in their office. But I understand that you have to be entirely comprehensive.
Yeah, and what if they come in the ER? There's the difference.
So could a checklist of different things be used so that it would be easy to include that for the agreement? This, and this, and the doctor checks. Is that allowed? Is that what the PAs do, Micah? The physicians supervising PAs?
Yeah, well, to a degree. So what we chose to do as the medical commission was provide, because we were getting a litany of formats that were turned in on the collaborative agreements. And so what we chose to do we chose to create an online portal and allow the submission that way. And so with respect to supervision and types of tasks that were allowable, we simply provided 3 general options that fit what we usually got, and then we provided a free text option if something didn't fit, so they could adapt to that. So that's something the Board of Optometry can certainly consider doing to make the administrative process easier. But that's up to them.
Right. Okay. Any other comments on this part? Seeing none. The next part is agreements.
Yeah, I have a question. So, and I have a feeling I know what the answer might be, but I'll ask anyway. The Board of Optometry didn't, in conjunction with Department of Health, didn't feel it's necessary to submit these agreements. And so I'm just wondering, the reasoning behind this, or if it's another standard procedure for collaborative agreement.
Micah?
Just going to stay on camera. Yeah, historically it's been pretty standard to do that. And frankly, in the law, we noticed that was a gap. And with respect to there was just no knowledge possibility of who was entering into the agreements. There was no ability to keep track of anything because, frankly, at the last minute, there was a amendment to that bill that not only didn't require the submission of basically anything on this line, but it also exempted it all from public disclosure. So the data that you would need to track complications, who was having them and who was responding, would never be found because it's not required to be released under any public disclosure. And I understand the intent. The intent was to protect patient identity and patient complications, but in the amendment process, it exempted everything under that section.
So, the optometrists know that if they're performing any of these procedures, they have to log that into the Department of Health. And personally, I just assumed, I don't really know what transpires afterwards, but I personally just assumed that those statistics were made available.
No.
Yeah,
And
this
that,
also
again,
helps the
that's
hospitals
for
now.
the optometrists. That's not for the ophthalmologists who we regulate.
Mhm.
Oh, I always had the understanding that the whole point behind documenting all of that was for people like ophthalmology to be able to have access to that.
No, there are reporting systems within the Department of Health, and frankly, that's really what item G is talking about, to make sure that there's comprehensive reporting. But we don't, as the regulators, get access to that. That's more of a public health reporting system, and because of the sensitive nature of it with respect to patients, their complications, their particular conditions, that's not widely circulated, and it's fairly well protected.
Uh-huh. We don't report names or patient information or anything in those reports either.
Mm. It's not something that's provided to us.
Okay. We're just gonna leave that as is. Is that right?
Yeah,
It's good.
I'm good with it.
Go to G. Melissa, you have a comment?
I do. So if I can confirm from the board's perspective that that information is available to the medical commission, for example, is it reasonable to remove this section? And the only reason I'm bringing this up is you've got the optometrists that are following certain procedures, and then you've got ophthalmology that's following other procedures, and it's creating so much confusion, and it seems almost redundant that we're both acquiring the same information, and in the hopes of making it so that it is not more complicated for the qualifying physician to enter into these agreements. If I can confirm with our board and the program manager and the executive director that all that information is made available, is that something that could allow either removal or modification of this?
Micah?
I mean, I suppose it's possible, but again, the law section in question has been exempted from public disclosure last I looked, and I can go back and verify that. But the law also applies to optometrists only. And so it is incumbent upon you to report for your regulatory authority, not the ophthalmologist who we regulate reporting to us about any complications. Now, I guess my question would be, how are you intending for that to be submitted? Is it an email to the Board of Optometry with the information?
No, there's a whole application online where you actually enter everything in, and you enter in the procedure, the date, the time, and then you submit. You can do it, every month or every time you do a procedure. It's all electronically submitted in that way.
I think I would argue that's a more burdensome process than what we proposed here.
But
And again, if it goes to the Board of Optometry, are you listing the ophthalmologist that you've worked with, or is it just
Well-
the complication?
well, we only have one agreement, so there's only the one ophthalmologist that we're working with.
Right, but I'm still asking if that individual is named as part of the rapid response complication.
So, okay, the way it works from the optometrist perspective is we have our agreement, we have the ophthalmologist's name on that agreement. We don't, because we're working with that one ophthalmologist, there's not a requirement that states every single time we have to enter the ophthalmologist's name. So, I mean, if that is a requirement in order to eliminate this two, both sides doing essentially the same thing, the redundancy, I'm sure that we can look into something. I would have to ask and see if that's something that could be modified.
Okay, because from where I'm sitting, you've asked to eliminate the submission of the form. You've also asked to eliminate the submission of any complications. Yes, you did. You asked just previously, why do we have to submit the form, and is that standard? That was your previous question, right?
No, what I was talking about was filing this specific G, the report, for each specific complication that occurs. So
Sure.
every time a qualified physician responds to any of a complication and then has to fill out this report, and it's stating details like date, time, procedure, outcome of the patient, and then submit that within 30 days to the commission. So every time they see a patient for a complication, they have to submit this, right? We're doing essentially the exact same thing. We're putting in all that information without names or identifying information. And so it's almost redundant because there's two things happening. Now, my understanding had always been, and I can verify this, that the reason we were doing that was so that other, whether it's the Department of Health or the medical commission wanted to see those complications, they could. There's nothing identifying about them. So it's not like we're releasing patient
Mhm.
information. So if I can clarify that on my part, all I'm trying to do is trying to make it so that it is not so cumbersome for qualifying physicians to enter in these agreements so that we can have more of them, right? So that we can provide the access to care. That's my end goal. I'm not
Mhm.
trying to, I also want people to be well taken care of. I want Washingtonians to be okay. I don't want complications to occur to them. But if you kind of step back and think the whole purpose of this is to provide an increase of access to care, and now there are all these additional steps that if I were an ophthalmologist and I looked at all of this, I would probably say this is too much, too many steps to get involved. I probably won't get involved. And now it just kind of defeats the purpose of the whole law. So if this particular step in particular, G, if we're already doing it and we agree that it is shareable information, is it necessary to also have it in your draft rules?
I mean, I think I would have two responses. The first is we've heard nothing from the Board of Optometry about even the submission of this information, let alone the sharing of it. So we'd welcome any information about that. The second is both you and Mark in this meeting have said that you anticipate that there will be 0.01 complication rates here. And so this would be an exceedingly rare event for an ophthalmologist to have to turn in. Right?
Right, but that's not the point.
I think it is
I
the
mean,
point because we're talking about data and patient safety and events.
So what he was talking about specifically was the complications from the ER, right, in his Lewis County. In Lewis County, the ER docs call the optometrists at his clinic down there for when there is conditions that they don't feel comfortable addressing and would otherwise call an ophthalmologist. There is no ophthalmologist on call, so they are the ones that take the call. So what he's talking about the 0.01% is it's that particular, these aren't even related to procedures. These are related to anything that walks through the ER that's unrelated to anything optometrist did.
Mm-hmm.
So you can't use that same statistic and apply it here because it's applicable. It doesn't apply to the same thing.
Yep. So I would propose that you check with the Board of Optometry about that information and getting it to us. And then previously, Dr. Domino asked you for national complication rates on these particular procedures, and we can come back to that once we've seen what you can propose.
Okay, thank you.
Thank you.
So just to reiterate something that Micah mentioned is that we have no authority over the optometrist. And so we added this in here because we need this data from the qualifying physician simply because we need to be able to track this information too, because that helps us develop changes to the rule. So if we have that information, we may know that we can change, like we may be able to take the number out of physicians that can work with optometrists. We may be able to remove that 10 cap because we have the data that shows us there's only a handful of these complications that happen. So that's more of a data collection for us that drives the rulemaking in the future. And we can't require the optometrist to also submit that report to us. We can only require the physician to do it. So I think that's why we have that in here, because we have authority over them. So just to add that in there.
Thank you.
Do we have more discussion of this or move on?
Well, G is really long, so.
Oh, I mean, down the page, I should say.
Yeah. This is all the requirements for what it needs to include.
Mm-hmm.
And I don't believe this form has been developed yet. And Mike, I would assume we plan to do something similar to what you mentioned, that we have a place on the website where they can just submit this.
Yeah, so long as this information is, if it's not coming from the Board of Optometry or Department of Health, then yeah, it would be just from a customer service perspective, we would develop the, name, rank, serial number form that they can easily submit, probably an online portal even.
Okay. So with that information in mind, do you have any comments about II through IV?
I don't.
I think we need to know about the, if we get the information from the Department of Health, then I think we need to know that, right? Rather than designing our own thing. So I don't know. I just leave it the way it is now and come back to it.
Yeah, agreed.
Okay, well, that is the end of this section, which was our main focus for this workshop. Are there any other questions about this section that we haven't already addressed or have a plan to change it in the future? I'm looking for that petition language so that I can drop it in there for next time. Okay, well, I'm going to stop sharing that and we can move on to our next section. Let me find it. I have too many windows open. Apologies. Here we go. We're going to talk about expired license is the next section we're discussing. Okay. All right. Thanks for your patience. Okay, so this is where we're starting in the rest of the draft. And then just a reminder that we do have several other workshops scheduled for this rulemaking. And then at the last workshop before we decide we want to move to the next step in the rulemaking process, which is proposed rules, we will go back through the chapter that we have here and we will talk about any changes that need to be made after we've already gone through all of these sections. So just know that this is not the last bite of this apple. You will get a chance to comment on it at future workshops as well as at the hearing whenever it is scheduled. Okay, so we've proposed some changes to the expired license section, and they are all here in red. Probably need to make this a little bigger. And both Marissa and Micah are here for any questions you have about these changes.
So
Micah, do you
Commissioner,
want to
just
tell us why we
yeah.
have this?
So historically, we've had sort of a gap in the renewal process when someone's expired. So there's essentially two flavors of this. You've got someone who's expired up to 2 years, and then past that, there's sort of a different standard. But it's been a bit nebulous with respect to, are we okay to activate someone's license again after, say, 3 years or more, when we have no evidence whatsoever of what's been going on? Maybe they can say that they've kept up with their CME and they just submit that, and it should be gone. Other times they've had an active license and they have not been licensed with us, and it doesn't appear that they've practiced for 15 years. Now, Ms. Blake can certainly speak to what happens on the hospital side when that occurs. But from a legal standpoint, we haven't had a lot of structure around this. and the need to at least say, show us you've been active in another jurisdiction to calm the minds of, say, the panel L who has to review a reactivation application and decide if this person is going to be safe to practice in Washington.
I agree with what's in here. I read it and I'm in agreement.
I'm
Yeah.
fine with it.
I'm fine with it too.
And then there's this section 4, which talks about if they haven't been engaged in clinical practice.
Mhm.
And this is largely based off of feedback from panel L commissioners when they see these. They're asking, are they going to have supervised practice, or do they have a reentry plan? Do they have a preceptor? The formal assessment, we don't specifically name it, but it's effectively specs. So that's a special purpose examination. That's usually what we use for this. And something that's more in depth, we may send them for a fitness practice, use it at PACE or something else like that to demonstrate clinical competence.
I read this section too, and I'm also in agreement.
I don't have a problem with it.
Yeah, I'm fine with it too.
Okay. And there's section 5.
Same thing, I'm good with it.
I'm fine with it.
Yeah.
And then 6.
Agreed.
Agree with that.
Yep.
So we're trying to change, instead of retired active, we're trying to change these to retired status. Just to make it a little less confusing.
Exactly, I like that.
There's a little typo there. Status should be, I mean, it's retire, let's add this, change to status.
I'm allowed to make up words, Dr. Chang.
I like
This
it.
is Heather.
Less
I will
confusing.
just say that retired active is what's authorized in the statute, that authorized this license type and that authorized the reduced fee. So I think it's fine to maybe call it something else, but I think you want to reference that so you can, I think it's free or like $25 or something for retired active in statute. So
I think it's
Would you feel better if it said retired active status?
I think that would align more with the statute, but yeah, I guess it's your preference, but I would somehow connect it. If you don't use that title, I would somehow connect it to make sure that doesn't get lost, especially like down the road, someone 10 years from now when we're doing rulemaking, like, what was this?
It's always a fun experience when we have to
Exactly.
So,
you know what I'm talking about.
I know exactly.
Could you define it in the
Yes,
first,
agree.
under number 1? Somewhere there in parentheses.
There you go. That might be another option, Dr. Domino.
So you're saying define it here and this.
Yeah, I mean, I
one.
like retired
And then-
status for the whole section, but I'm wondering if, somehow you could reference there the retired active status, whatever you, I don't know how you connect them, but to explain that for people.
You know how in a document where you say, give the definition and then, but it's going to be called this in the body of I forget what that wording is like. Yeah.
So we can define
My
it
brain-
here or in the definitions, but I would rather define it here. So
Yeah.
Yeah. The statute is 18-130-250. And it's no
So-
renewal fee. So that's why I think you want to, it's in statute that physicians don't have to pay any renewal fee for that.
And then somewhere put otherwise known as status in this document, or how, I don't know, I forget how that gets worded. My
Mhm.
brain's a little bit tired now.
So I think we could probably just come back to this section then, revisit it later.
The other way you might be able to do it is to put that citation as part of like the authorized rulemaking, the authorizing. You know how when the
Mhm.
rules are online, they have the references to yeah, so maybe that's where you'd put it.
So Heather,
So you
it-
could
it
do
would
that in the
read-
paperwork.
It would read to change the status of their license to retired under as, as referenced in RCW, whatever
Sure.
the reference is.
Mhm.
And the statute does say license status. So using the word status, I think is consistent. I just want to
Okay.
make sure retired active. But it's officially retired active license status. So
Mhm. Well, to your earlier point, I think we have something like 4 flavors of this, but the statute
Yes.
doesn't speak to it.
No.
Yeah.
In state, out
In
of
state,
state.
out of state, active,
Voluntary.
inactive.
oh,
Yeah.
gotcha.
Right.
Yeah.
Yeah.
It's very confusing.
Yep.
Yeah.
I agree.
Sorry to throw a wrench.
No, it's good.
That's
Thanks.
why you're
No,
here.
it's helpful.
Yeah, it's good.
Yeah.
Okay, so
No worries.
I'm
Are we
sorry,
gonna
which-
then do that, leave that for later on? Another
Yeah,
day?
we will come back to this one at the next workshop.
Wordsmith it a little bit.
Yeah, we'll
Mhm.
start
Yeah,
at 480 for the. Oh, I think
I know.
she's okay. We've got her muted now. Yeah, we will come back to this one. Okay, and then do we want to go ahead and I don't think we should start on 490 because it's a very long
We
section.
only have 4 minutes left
Yeah.
to do it.
So we
I-
will start at 480 for the next workshop.
Okay.
And we'll have some new language in there. I'll also find that petition language for the exception. And then
Okay.
I will plop that in next time. We may not discuss that section again next time, but the new one. But it will be in there for everyone to see it. So, but we will discuss it at the final workshop, whenever that is.
Okay.
Okay, so I guess we'll stop for now. Thanks everyone for your participation. Ms. Boyd, do you want to say anything else about the next steps? I don't know if you have
Yeah.
a slide related to it.
I do have
Or-
a slide
yeah.
related to it. You
Well,
know
she'll
me.
talk about the next step and schedule for upcoming workshops.
It's going to start at the beginning, so I apologize for that. Okay. So the next steps in this rulemaking process are these additional workshops. The revised draft language should be available on this rules page, which you can navigate to by clicking the link on this slide sometime within the next 2 weeks. And then a notice when it's posted will be sent out via our Gov Delivery distribution list, as well as when the materials for these workshops are available will be sent out through that as well. And then also available on this rules page are the materials and recordings from previous workshops. So the page for each rule that we have in process right now is like a one-stop shop to find the current draft, future workshops, all of those things should be on there. So, and then if you have any questions, you can send them to the medical.rules@wmc.wa.gov.
Great. Are there any questions of people who are here in the audience right now? Don't see any hands raised. So if no one else wishes to speak, I'll close the workshop. And right now it's 2:43 p.m. And thanks everyone for your participation.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Bye.